Hello, this is your brain on drugs and the punk rock psychiatrist. So today I'm going to be discussing how to pick an antidepressant, right? So we've kind of gone through them all. I've given you my pluses and minuses of each medication, and I wanted to kind of put that all together to try and give you a relative formula-esque that you could follow when you're seeing patients to try and pick the best medication for each patient. Okay? So let's go through some of the factors that I'm taking into consideration when I'm going to select a medication. So, first, I'm just going to go through a list of all the factors that I'm looking at, and then I'm going to go into detail on a few of those factors. All right. So, first factor, and I've list these relatively in order of importance. It's not hard and fast, but I'm the stuff I weight the most, I'm kind of putting towards the top of this list. So the first thing I've actually listed is patient preference. Now that may be surprising, but also perhaps unsurprising, right? So I tell patients about the different options. I tell them generally what to expect, plus and minuses, what the side effects are of different meds, and I give them a few ideas, and I let them pick. Or if they want me to pick, I'll pick, or I'll suggest and see if they like it. If they come in kind of already thinking, I have a friend that took this and seemed to really work. You get this a lot. Patients come in and they had a friend or family member, or maybe they read online something bad about a medication. Even if it's whatever's bad about it is extremely unlikely to happen. If you try and push a med like that on them, then they're likely to get the nocebo effect. Or we talked about the placebo effect, where you get a positive response that's not explained by the chemistry of the drug. A nocebo response, noci meaning pain, is when you get a negative effect. So you get a side effect that's not really accounted for by the chemistry of the drug, but it's kind of like the negative side of a placebo. Placebo meaning pleasurable and noci meaning pain. So placebo and nocebo. So if they've got a negative impression, they're more likely to get a nocebo. And if they've got a positive impression, they're more likely to get a placebo. And so I like to go with and even if it's maybe not my top choice for the patient, if I feel like it's a reasonable and safe option, what they want is more likely to give them the response that we're looking for. Okay, so I rank patient preference my top factor when selecting an antidepressant. Now, probably most of the time, patients don't have a preference. This is in cases where they do. All right, and then like I said, I give them information, and then they may express a preference after I've explained how the medications work. Next, um, previous response or familiar response. Okay, so have they taken something before and it worked? Well, let's do that again. All right. If they took it before and maybe it worked for a while and then didn't work, they're probably going to be reticent to trying it again because they'll remember how they felt at the end, even though having gone off of it for a while may mean that the tolerability that they may have had to it will have gone away. And I'll explain that to them. And if they're like, you know what, um, I understand that. Um, I'd like to, I know what that one did. I know it did work. I know I tolerated it. And perhaps it was just tolerance. I haven't been on it for a few years. I would like to go with that again. So they may want to go with something like that again. Or they may feel like, it just wasn't working at the end. I'm not sure if it ever worked. And then let's just table that one, right? Let's not use ones that they have some sort of negative association with. So, but if they had a great response and then they just came off the med because they didn't want to take meds anymore, they thought they were better, they did well for several months or years, and now they're having issues again, they want to go back on something, let's go ahead and go back with what we already tried and worked, right? We already know they tolerated this drug, that we already know that they responded well to it. So that's a big factor for me. And so I said previous response or familiar response. So if they've got a family member, so we're talking about mostly first degree relatives here, parents and siblings. If they have a family member who is on a medication or who has taken one and has responded well to it, there is kind of some genetic thoughts that, like, they're more likely to respond to this medication and tolerate it as their family member did. Also, they're more likely to kind of have a better thought about the medication if they saw a family member taking it and saw a positive response. Okay, so there, I think there's a placebo you're getting out of that, and there's also some genetic chemical benefit that you're getting from it as well. All right, so that next one was their previous response to meds or someone in their first degree relative, but maybe even beyond that, just from a, they know somebody close to them who took it kind of thing. But from the genetic standpoint, I think you're mostly getting benefit if it was a sibling or parent. All right. Perhaps child as well, but typically parents who are not going to be starting after their children. So next, side effect profile. Now I foot stamped the heck out of this one. Um, those top two, I think, are just massively important from like a genetic and placebo and preference standpoint, and that's why I put those two first. And but then, in lieu of that, we don't have a preference, we don't have previous experiences, we don't have family members who have taken it. I'm mostly looking at side effects. I've talked ad nauseum about this in the past. I want to pick the medication that I think is going to be the most tolerated by this particular patient and all patients in general, right? So, what's the most tolerated medication, and what specific things about this particular patient may make, are they obese? So I don't want to give them something that's going to cause them to gain weight, things like that. And this is one that I'm going to go into a little bit more detail on in a subsequent slide. So, I'm going to move on from there for now. Next point is interactions. So we're talking about drug-drug interactions here. If they're taking other medications that the med I'm going to start them on is going to have an interaction with, or the drug they're already on is going to react with the med I'm starting, I want to take that into consideration. And preferably, I'd like to avoid medications that are going to have interactions. We have so many choices with our antidepressants, and they do all kind of they cover the gamut of the different enzymes. So we've got ones that are processed by 2D6, 3A4, 2C19, 2B6, right? So we could kind of take the ones that fit their medication profile the best to avoid those interactions, because they all work. Remember, they all work kind of the same. They're all pretty likely, equally likely to work, and so if I can pick one that they're less likely to get an interaction with, that is going to help us avoid side effects and improve efficacy. Okay, and in that same vein, I like to think about, is this a med that would interact with meds that they're not taking but could be taking in the future, right? Is this a strong 2D6 inhibitor? Is this a strong 3A4 inhibitor? Something like that. I'm generally going to want to try and avoid those. So fluoxetine 2D6 inhibitor, Paxil 2D6 inhibitor, I'm going to rank those a little bit lower because, maybe they end up on something that's 2D6 in the future and I don't see them and I can't help with that. Or, you know, even if I do know about it, we're on this med and it's working well for them. And I don't really want to switch it at this point. But now we've got this new medication in there we've got some problems with. So I'd like to pick meds that don't cause that and bupropion is the one exception because it's so unique in how it avoids like a lot of side effects that a lot of other medications have, and so it's I think more tolerable in general, and has a unique mechanism of action, and it is a strong 2D6 inhibitor. That's the one that I will kind of overlook the interaction piece with. But of course, if they're taking something that would interact with, that's something I would take into consideration. But future interactions, I would be less concerned about with this medication because of those bonuses and those positive aspects of the medication. So I'm thinking about interactions, present and future. Next, indication I put in there next. So we're talking about FDA indication. Um, Pretty much all the meds that we've talked about are approved for depression. Some are only for like OCD, anxiety. Some are for pain syndromes only, like milnacipran, fluvoxamine for OCD. So depending on how drug coverages work with the patient's insurance company, you may need to keep that in mind. It's just something to keep in the back of your mind from an insurance coverage standpoint, and also just kind of covering your own self of, am I going off label and using something, up to this point, pretty much everything that we've talked about, even the ones that are not necessarily specifically approved for major depression, they're all fair drugs to use for depression. There are some medications that are off label that we have not discussed that I'm going to discuss fairly soon when we talk about medications we can use to augment the medications we've already discussed. Some of those are not approved for depression. And so you have to think a little bit harder about that. Do I want to give them dextro amphetamine stimulant or not? It's not really indicated for depression, but it may help augment. So that's something that you want to keep in mind. Okay. So, next point, thinking about the severity and the type of depression and the symptoms that they have. Okay. So, remember, generally, with the more severe cases of depression, these antidepressants are more indicated. And for the mild to moderate, I'm thinking more about therapy and lifestyle modification as better treatment. So, and some of the treatments are going to treat more severe cases. So you've got things like esketamine and ketamine that are maybe a little bit more effective, a little bit stronger treatments. ECT, something we haven't talked about yet. If you got more severe cases, you've got suicidality and things like that. Maybe you're going to think about bringing out some of the bigger guns to tackle that. So, thinking about what the severity of the depression is, how many drugs have they failed in the past with other providers that they've seen or ones that you've given them, that's going to come into play as well, as far as, which ones we're going to pick, right? And which ones they've failed before. If they've failed, let's switch to a completely different drug class. Let's try something completely different, as different as possible. A lot of serotonin ones, but let's try something that's not like that. Let's try, something different. So you're going to think about that as well. And then the type of depression. I'm going to go through depression subtypes in some separate episodes. I'm talking about psychotic depression, depression with anxious distress, melancholic depression, um, depression with mixed features, which is mixed features of like mania and hypomania and so forth. So for those subtypes of depression, there are specific medications that would be more indicated to use in those cases. And I mean, there are specific and treatment resistant depression would be another one. There's only a handful of medications that have the approval for that, and a handful of other ones that may be beneficial but don't have the approval. And so I'm going to have episodes on each one of those subtypes. And so when we go over that, we'll talk about what medications have the most evidence for working in those subtypes. So that's another thing that I consider when I'm selecting an antidepressant. Next, financial consideration and availability. So availability, obviously, if you're in a rural area and your pharmacy doesn't carry, some of the more unique and newer medications, um, it would be silly to prescribe those. That's something you have to consider. Financial consideration, does this patient have insurance? What kind of insurance do they have? What does their insurance cover? I don't want to prescribe something that they're going to have to pay out of pocket for or have a large copay for, especially when there's something that's, much cheaper and just about as easily able to work. I've seen this where the newest drug may, the office has samples of this and they're giving samples and coupons. And I feel like this is all a tactic by the drug company to try and get us to prescribe more. Because why are they giving us free stuff, right? They're giving us free stuff so that we get used to it, we get familiar with it, and that becomes our drug of choice. And then what happens? Then that becomes the drug that we're prescribing in the future in cases where we don't have coupons and don't have free samples, and maybe to the same patients who now, how are they going to get it? So I'm, luckily with pretty much most of the medications we've discussed thus far, they are off patent and inexpensive. Only the last like maybe three or four. I mean, I'm thinking about Auvelity, esketamine, um, gepirone, and vortioxetine. those are the ones that are the most expensive and not, that there is no generics available. And so most of our options are cheaper. And, I was just, I saw the other day, I was not familiar with this and I don't know how this slipped by me. And when you see the artwork on the dosing episode, which was a couple episodes ago, or maybe it was, yeah, a couple episodes ago, the artwork, I have different pill sizes of Prozac as the art, and there's a 90 milligram. And I don't, maybe I forgot about it or was not aware. There's a 90 milligram Prozac weekly. You take it once a week. Delayed release Prozac. Prozac already has a long half life, and now we have this delayed release version that, and apparently it's been around for like over 20 years. I don't like know how I didn't notice this. It's just I've never seen it. I don't know how available it is, but it does exist. I guess it's like, oh, you only have to take this once a week. And I was looking at and so I was looking at the prices of Prozac and fluoxetine. Uh, Fluoxetine generic can actually be as cheap as 7 cents a pill. It was like between 7 cents and $2 a pill. But name brand Prozac is as much as $30 per pill still, right? And that's pretty expensive. Okay, so these products that are not generic cost tens of thousands of dollars a year. Um, and that may not be costing you anything. It may not be costing the patient anything if they have the right insurance, but it's costing our healthcare system a lot of money. And honestly, the newer treatments we have really aren't that much better than the older treatments. And I don't think they're that much more likely to work. And so I'm thinking about that cost when I'm considering what medication I'm prescribing. And I think having practiced in the military, that was something that was kind of forced on us. We had these formularies that we could pick from, and if you wanted to pick something that was non-formulary, you had to have a special, you had to be the specialty. So like family medicine wouldn't be able to order it, but I would if it's a psychiatric drug. And they would have had to fail, two, three, four medications, and then they would list which ones, and you have to fill out all this paperwork. So they made it burdensome. In many cases, I felt like unnecessarily so for certain medications that I really didn't feel like I had any other options. They were just trying, Vyvanse was an example of a medication I frequently prescribed that I thought was in many ways superior to the other options, and it was quite cumbersome to be able to prescribe it. Viagra, another one, really aren't any other options. And it wasn't just that, all the PD5 inhibitors. So they would make that challenging. You have to fill out paperwork. They had to be certain ages. They, it had to be like induced by SSRI or something like that. But I had to fill out these things and sign them. So it makes me kind of aware of like what's more expensive. And so that is something important to consider. Next point, half-life. All right, most of our medications are kind of an average 24, 36-hour half-life. We've got a few medications that have short half-lives, venlafaxine, most of the SNRIs, um, uh, uh, paroxetine is another one, fluvoxamine is another one, but we do have control releases of both of those. And even the extended release venlafaxine is still a short half life. The IR version is a very short half life. So the ones with shorter half lives, we worry more about patients going into withdrawal and getting those withdrawal symptoms if they miss a dose, or if they take it late. And then we've got some meds that have longer half lives. So this is mostly fluoxetine and vortioxetine. So we have a little bit more wiggle room there. If this is a patient that frequently misses doses, they're maybe going to tolerate something with a longer half-life a little bit better. So if they're a very diligent patient and they always take their meds every day on time, we're going to be less concerned about those ones with shorter half-lives. So kind of knowing who your patient is and picking, for most patients, we're going to go for the average half-lives, but we may, think about the shorter and the longer ones depending on the patient there. So I'm thinking about half-life when I'm picking a med as well. Next factor, suicidal ideation, risk of overdose. This sounds like, maybe the most dangerous of all, and I've listed it quite low, and that's just because it's not something that I take into consideration that often. And the main thing here, right, is risk of overdose, right? If they're having suicidal ideation, that's a symptom of depression. That's an indication to give them a medication. However, the TCAs are the riskiest to take an overdose, and the MAOIs also risky in overdose. So we typically are not prescribing these medications readily for depression. When I do give them, I give them extremely low doses for something like sleep or pain, and at doses that low, you could take the whole bottle and you're still not kind of over the dose that would overdose the patient. Would I give them a 90-day supply of 10 or 20 milligrams amitriptyline? Maybe not. A 30-day supply, they could take the whole 30 pills, and that's essentially the the daily max, right? So the daily max is 300 milligrams. And so if I'm giving them 10 and they take 30 of 10 milligrams and they take 30 of them, they basically took the daily max. So I'm less concerned about if, it's a serious thing for them to take the overdose, but the risk of them dying from it is what I'm talking about here. All right. So, but if I'm prescribing a TCA at the therapeutic doses for depression and they take the whole bottle, this is something that easily could kill them. All right. So, I am thinking about what is the risk of overdose with with a particular patient, if I'm considering giving them a medication that they could overdose and die from. But luckily, most of the medications that we use, the newer medications, don't have a huge risk of death if you overdosed on if you took the whole bottle or something like that. Okay, but something to consider depending on what you're doing and on the patient. All right, next, comorbidities. So do they have other medical disorders, other psychiatric disorders, that may lead us to pick one med over another? Am I trying to help their anxiety as well? Do they have some delusions or psychosis as well? Am I going to think about an antipsychotic maybe, and one that has more of an antidepressant effect? So things like that. I'm gonna have a separate section in this talk about medical issues where you would where that would lead you to pick that. So I'll talk about that a little bit later. And then another one would be substance abuse history. And so, is this a medication that they are more likely to be able to abuse, or could help with this, or something like that? Well, luckily, most of the medications we've talked to up to this point are not terribly abusable. The only one that I'm aware of would be bupropion. I've heard of abuse of bupropion. It's not terribly common. It is an amphetamine-like medication, so I think it's possible to crush and snort it and things like that. It's not something that happens a whole lot, but of course, if you were suspecting something like that, you would want to avoid a medication like that. Okay. Next, we have age, and this is one I'm going to address separately. So I'm going to talk about that there's certain medications that are approved for pediatrics and recommended for pediatrics, and we're going to have an episode on that down the line. So I won't talk about it now. I just bring up that age is a factor. And then also elderly patients. There are some medications that are higher risk, as far as, maybe causing falls, or anticholinergic, to cause deliriums and memory issues. So those are things that I would take into consideration. Once again, I'm going to go into detail on this in another episode, but I just bring it up today to mention that age is a factor when picking a medication. Next, pregnancy and breastfeeding. I'm going to do a whole series on pregnancy, breastfeeding, postpartum, menopause, premenstrual, like all those type of reproductive issues. And just to mention it now, if they're trying to get pregnant, or they are pregnant, or they're breastfeeding, there are certain medications that we like to prescribe more often than others. Typically, we go with older meds that we have more information about. And if there's ones that we have information that there may be a tiny negative to, we would want to avoid that one. Think about paroxetine in pregnancy. However, breastfeeding, it's quite fine. But we'll go ahead and go through that in a completely separate episode. But this is another factor that I use when I'm picking an antidepressant. And then lastly, based on symptoms. And, I think I put this last to make a point of just, I don't think there's the medications all work are all pretty much likely to work on the average patient in the average amount of time. Do I take this into consideration with? Yes, I do. I absolutely do. I don't think it is as important as all the other things I've mentioned above, though. It may be the main thing that you're concentrating on, the main thing you're thinking about, because maybe the other things aren't a factor. They're not pregnant. They're not breastfeeding. They're not pediatrics or elderly. They don't have any comorbid conditions. There isn't the risk of suicide. The half life, you're not really concerned about half life in this patient. Financial considerations for the meds you're considering are not an issue. Availability is not an issue, right? So if a lot of these other factors are only factors if they're a factor for that patient. And for a lot of patients, none of the things I mentioned up to this point are factors. So then we are thinking more about symptoms. But I do think those other things are more important to address first if they are an issue for a particular patient. If we've gone through this huge list of things that help me pick the med, and we haven't really come up with any reason to pick a med or not pick a med, right? Then we're defaulting to side effects and symptoms. Those are the two main ones, right? If none of the other things come to play, those are the big ones. And patient preference, of course, which most patients will have a preference, especially if you do explain options. I'm sure there are a lot of folks out there, they don't have a lot of time. They're not giving a lot of options. They're just kind of saying, let's start you on something. And they just give them something. And they don't really tell them that there are other options, right? I've always had more time. I honestly, I think a lot of people spend a lot of time checkboxing things, going through these huge histories and checking every little box of how many siblings do they have and all their social history and the history of every drug they may have taken at any point in the past and how old they were and how long they took it for. I don't find a lot of utility in taking this detailed of a history when it takes away from things that I feel like are more important. If I've got a limited amount of time with a patient, I definitely want to have time to spend with that patient to talk to them about, problem solving, what's actually going on, like drilling down and, is this even depression? Is this maybe a sleep apnea? Is this maybe a thyroid issue? Is this maybe a partner relational problem, right? I want to, find out, do we even need to use an antidepressant? Is there something else that can explain the symptoms of depression that they're having other than a major depressive disorder that would indicate the use of an antidepressant? So I want to spend a lot of time first diagnosing and figuring out why this is happening. And second, I want to spend time explaining to the patient what their options are and what to expect from the medication, what to look out for, what to be concerned about, what not to be concerned about, counseling them how to take it. Um, if there's some flexibility in how they can take it and change the dose. Those things are way more important to me. And if that's all I have time for, that's all I want to do. Of course, having a full history is nice and it may reveal things. And when you're starting out and you're learning and you're a student, it's very important that you do that. But for me, I feel like I'm able to pick up on these things and drill into them if they're an issue, rather than spending a lot of time on that. And if something's piquing my interest and I'm thinking there might be something going on there, I'm going to drill down more on it. Um, but another issue is if you ask a patient a million questions about things that probably are not going to help you solve their problem, they may end up telling you their life story about a bunch of stuff, which it can be important. However, if it takes away your ability to actually like find out what's actually going on and come up with a treatment plan and discuss that treatment plan with the patient, then you're shooting yourself in the foot doing something like that. Okay, for me, the diagnosis and the treatment plan and the counseling are the most important factors. All right, so um, that's kind of how I go about it. So and if I figure out that none of these other things are really an issue, I will take their symptoms, of course, into consideration, and I'm going to talk about how we do that. So that's an overview of all the different factors. That's everything I could come up with, as far as and the one thing maybe I didn't mention on the comorbidities for medical disorders, I also want to know is there a medical disorder, right, that's causing the symptoms? Um, I've found out in several situations people are sent to me for depression, and maybe it was a concentration issue, an ADHD issue that was causing this. Maybe it was a substance use issue. Maybe it was a medical problem, or maybe it was, I've had one that even had like a prostate issue that was affecting sleep and then leading to symptoms, right? Because he was getting up peeing all the time. So there may be something else going on. One thing that I like to do as a psychiatrist that, you know, when you're a specialist, I think a patient's sent to you and you're a specialist, and there's an assumption that this patient is having a problem that has a disorder that is in your wheelhouse. I make the opposite um, assumption. I assume that this patient should not be seeing me. I don't tell them that, and I don't act like, hey, get out of here. You don't need to be seeing me. But I make the assumption when I first see them that they don't need to see me, that they have a problem that is not psychiatric in nature. And I need to prove to myself that it actually is a psychiatric disorder before I start treating them, rather than the reverse of, oh, they're coming to see me. They've got symptoms of psychiatric disorder. This must be a psychiatric disorder. Let's figure out which one it is and what treatment is best for it. I first want to see, well, because if it's not that, if it's something else, and I'm not thinking about that and looking into it, then I'm going to miss something, right? And then I don't even have to worry about picking an antidepressant. So, but before I even pick an antidepressant, I need to figure out if I even need to pick an antidepressant, if that makes sense. And I'll probably have an episode where we go into more detail on how to do that later. So, but for now, let's drill down on some of those topics that I mentioned when we're going to go into how to select an antidepressant. So let's talk about picking one based on adverse effects. Okay, so side effect profiles. So if you've got a patient who has sexual dysfunction already, or is concerned about it, or is taking a medication that's causing it and that's preventing them from wanting to use it, I'm going to be thinking about using medications such as bupropion, mirtazapine, maybe trazodone, things that don't cause this. All right. And unfortunately, most of them do. All right. There are only a handful, and those are the three main ones that I think about. Maybe a vortioxetine is a little less likely. I mean, it's less likely, but still a culprit. And then also, there are a couple SSRIs that are a little bit worse than the other ones, paroxetine and fluoxetine. So maybe I want to avoid those two, or if they're already on them, maybe I want to switch. Okay. Or if they're already on something, I might want to lower the dose. Now, I had a whole 2 episodes on sexual side effects, so I'm not going to go into a ton of detail now. Just that, if they're having that or that's a concern, that's going to be one factor that I have whenever I'm picking the medication for them. Another factor would be patients concerned about weight gain or are already overweight or obese, right? So with these patients, once again, I'm thinking about bupropion. It's more likely to lose weight. In fact, we have the contrary, bupropion naltrexone, which is used for weight loss. So bupropion is your best option. And then we're wanting to avoid things like paroxetine, mirtazapine, and even the TCAs as well. So those are the biggest culprits. Bupropion is really out of everything. I guess the ketamines would not really be a weight gain issue, but those are not commonly given. But pretty much most of the rest of them do have that risk. But that's something, and this is one reason why I like bupropion, right? Because weight is a huge issue, especially in the United States. Almost all of these medications can contribute to weight gain. The SSRIs are not super likely to, but if the patient feels like they are, um, we might go with bupropion. Okay, so that's another side effect mediation strategy. Another one is inflammation. This is not something that I've ever actually used, but it's intriguing to me and something that I might want to incorporate, and something that maybe more information is going to come out in the future. So there are some studies that suggest that a high CRP, that C-reactive protein, a measure of inflammation, has indicated a better response to the following medications: tricyclics, dopaminergic medications like bupropion and pramipexole, dietary changes, omega-3 fatty acids, and having a lower response to SSRIs. Now, there are no guidelines that say that we need to check CRP before every patient and then pick one of these medications to mediate it. SSRIs being something that would be less likely to work. But once again, here we have bupropion. Um, bupropion is it's come up in all three of these, for the weight issues, for the sexual dysfunction issues, and even the inflammation issues. And so I've heard of people saying, "Oh, I check the CRP, and then if it's high, I give them bupropion." It's like, well, I don't need to worry about that because I already gave them bupropion. I don't need to check this lab and deal with this. I'm just I just gave it to them already. It's going to be my first or second choice anyway, unless they have some sort of reason not to do it. All right, so that's another interesting thing, and I think there's growing information about this idea of inflammation and that what medications might be more effective for that. So that's something you're probably not going to take into consideration, like the weight and the sexual dysfunction, but it's something that I think there's some intriguing things going on there, and we may be seeing more in the future. Next, selecting based on predominating symptoms. As I mentioned, I feel like this is less important than managing adverse effects. And of course, I didn't go through all the adverse effects that someone can get. Of course, there's GI effects, and sertraline being worse for that. There's another one that's a little bit worse for that. And then some of the rest of them being, maybe more even on it. The ones that don't affect serotonin may be a little bit less on that. Once again, bupropion, although it could cause some nausea, but not so much the loose bowel movements. So, you might take into consideration GI adverse effects. You might, there's a whole host of adverse effects. I just gave you the most common examples. Um, and so depending on what effects they're getting or they're afraid of, is going to be which one I'm going to pick. But before I pick a med, those are the main ones that I'm thinking about. All right. So now we're going on to talking about a symptom approach. What is their symptom and what maybe is the best medication based on their symptom? Okay. So you've got a patient, primarily low energy and hedonic. Once again, I know you're thinking bupropion, and you're thinking that I must be a sales rep for bupropion, but I am not. If you've got the low energy anhedonic patient, antidepressants with norepinephrine effects may be more likely to work. So we're talking about SNRIs like duloxetine and venlafaxine, bupropion, and even stimulants like the ADHD medications, which we'll talk about in a later episode because they're not FDA approved for depression, but could be used as augmentation. Also, fluoxetine, if you remember, it's got some effects that are other than its SRI capabilities that can increase norepinephrine, and therefore it may also help, maybe a little more activating and help with that low energy. And then a couple more that kind of theoretically may help, vortioxetine being one of them, and then cariprazine, the antipsychotic, has got some information on it that may be useful for this. And then pramipexole, again, a dopamine agonist, off-label, but something that may help with this as well. And then what medications would we want to avoid in patients that are having low energy and anhedonia? So ones that are more sedating, right? So we're thinking about paroxetine, mirtazapine, trazodone, medications like those. The tricyclics, those are the ones we want to avoid in those patients. Another symptom that may come into play are patients more anxious and irritable. Um, I think we think a little bit more often antidepressants with serotonergic activity like the SSRIs are a little bit better for this. But when I talked about bupropion, I said, a lot of people would avoid bupropion in this case. Um, I would say that SSRIs are probably a little bit better, but that doesn't mean you can't use bupropion. It's still could be effective. It may be a little bit more likely to make anxiety worse. However, it still helps a lot of patients as well. So if you have questions on that, listen to the bupropion episode for more details. But yeah, I do think a little bit more about SSRIs in the anxious and irritable patient. All right, and then I mentioned that we were going to talk about if they had a medical condition, right? So they've got a medical condition. It's not the cause of their symptoms. It's a comorbid issue with the depression. And what are those, and what decisions on medications might we make in response to that? So say they've got hypertension, cerebral vascular disease, something like that. So they've got uh, cardiovascular disease of some type. So we might want to avoid medications that have more of the norepinephrine with these patients. venlafaxine, duloxetine, bupropion, the tricyclics, MAOIs. So these have a little bit, they have more of the norepinephrine going on, which could make this issue a little bit worse. Not necessarily will it. In some cases, you might want to try it first and see if their vital signs got worse. If it was just a minor issue, I might do that. But if they've had serious cardiac issues, you might be a little bit more careful with those medications. So that's something to take into consideration, and think more about using the SSRIs, right? Avoiding the norepinephrine meds. Another medical condition, diabetes. So I don't, we're a problem with diabetes that can make it worse is gaining weight. And so using meds like paroxetine, MUIs, tricyclics, mirtazapine, trazodone, because they can contribute to weight gain, that can worsen diabetes. So I would generally think about avoiding those. And I also have in here avoiding 3A4 inhibitors. There aren't a whole lot. It's mostly nifazanone and fluvoxamine. And the note in here is that there's a drug-drug interaction with sulfonylureas. These are medications that are rarely used for diabetes anymore. Okay, so I don't see sulfonylureas, especially after the GLP-1s came out, and we've got the SGLT2 inhibitors. We don't really use the sulfonylureas anymore, and we don't use those 3A4 inhibitors either. So this is less of an issue. Um, Patient with Parkinson's. Um, Something like bupropion would be preferred, right? Because Parkinson's is a depletion of dopamine. Bupropion can help increase dopamine, so it might make more sense to try bupropion. And then we'd want to avoid something that depletes dopamine, like antipsychotics, which we often use as augmentation for depression. We're going to talk about that a little bit later episode. And also amoxapine, which is a tetracyclic, but has D2 blocking. We would not want to use that. I know we rarely use amoxapine for depression, if ever, but you certainly wouldn't want to in someone with Parkinson's. All right. Next disease state, HIV and AIDS. So a lot of the medications that are used to treat that are processed by the 3A4 system. So we're going to want to avoid nifazanone, fluvoxamine, and other 3A4 inhibitors in patients that are taking treatments for HIV and AIDS. Okay. And just generally, if I can't list everything, but they're, meds that are processed by a whole host of different things. You need to take that into consideration. So next is seizures. So if someone has an issue with seizures, we're going to want to avoid bupropion and the tricyclics because those can lower the seizure threshold. The patient already has seizures. We don't want to make that issue worse. All right, so those are some of the factors and some of the details of the factors I use when I'm picking an antidepressant. And for the next few, I'm going to kind of go over not a basic algorithm of like what are more my first choices, second, third, fourth. And then I'm going to talk about some of the guidelines that are out and what they recommend. All right, so here's my kind of basic depression treatment algorithm. First, and I'm sure if you've been listening up to this point, none of this is going to be a surprise. My first choice would be either an SSRI, typically escitalopram, or bupropion. And sometimes I'll go duloxetine, but typically I'm going escitalopram or bupropion. And then second line, if I haven't picked bupropion yet, I'll pick it second. If I already did try it, I will go for an SSRI like escitalopram, or if I did an SSRI and I don't want to use bupropion, I might use a different SSRI, or I might use an SNRI, typically duloxetine. And then third, I'm going to pick something from that list that I haven't used yet. So whether it's another SSRI or an SNRI or bupropion, I'm going to be picking, basically those three things: SSRI, other SSRI, SNRI, bupropion as my top three choices. And, I'd also probably add mirtazapine in there as well as something I'd probably put in the top three. So then fourth line, at this point, we've already tried three pretty standard treatments. And we're getting to a point where we're reaching a level of treatment resistance. And I believe treatment resistance is 4 failed treatments. I will have an episode on treatment resistance. We'll go through that in a little more detail. So fourth, this is when I'm thinking about an MAOI. This is when I'm thinking maybe about a tricyclic, and this is when I'm thinking about ECT. And, ECT is actually really effective. It's really commonly done. And I think a lot of people think of it as this, maybe somewhat dangerous, cumbersome, unavailable procedure, but it's actually one of the most common procedures done. It's more common than a cardiac cath. And it's actually very safe, and it's been around for a long time. And it's out of every depression treatment, it has the highest level of effectiveness, and it's effective for a lot of things that the other ones aren't. So, you're certainly not going to want to use it first, but once we've kind of tried 3 things or 4 things, we're thinking about ECT, and then we're also thinking about MAOI, and TCA. I don't know that TCAs are that much more effective than the other antidepressants, but you certainly could give them a go. And then fifth line, I would say, use something that you didn't try from the fourth line. The MAOI, ECT, TCA, pick one of those for fourth, and then pick a different one for fifth. And then also keep in mind that you could use augmenting agents. So that would be a second med. You could use that along any step. So you've maybe done the first step. If you've gotten a little bit of response from something, you don't want to completely throw it out, but we need some more help. We could add an augmenting agent. I'm going to have an episode on using augmenting agents later, and we'll talk about what those are, which ones, you might want to think about first and for what reasons. But that's my basic algorithm. And then this is a new one I came up with. I mentioned this when I was talking about Gepirone. I've come up with a tier list. S, A, B, C, D, E, F tiers. S being the highest tier. I think S stands for like supreme or superlative. And I'm going to, out of all the meds that we've talked about, I have placed them all into one of these tiers. This is my own personal tier list. It probably is not the same as yours or anyone else's, but I just want to kind of go through it so you can kind of get an idea of which of the meds we've discussed I have the most, I like the most towards the least. Okay. And so in the S tier, I actually have placed no meds. I've put lifestyle modifications and psychotherapy, right? So lifestyle modifications being diet, exercise, sleep, social relationships, um, being active and learning and thinking and getting outdoors, and those type of lifestyle things. Because from my standpoint, the lifestyle and therapy has no side effects, no drawbacks, and they actually are more likely to work. They may be a little bit harder to do. I mean, it's easy to swallow a pill, but if you're willing to put in the work, you've got a patient willing to put in the work and the time, and they have the resources available, these are more likely to last a long time. They don't have adverse effects, and they're more likely to have a higher likelihood of response. And as you know, I don't think that these meds are the end all be all. So I placed no meds in my S tier. All right. So moving on, A tier, I have put bupropion, duloxetine, and escitalopram, as I just mentioned on the last slide. Those are my kind of my top choices. Everyone knows why bupropion. Its biggest downside is it's a 2Z6 inhibitor. I really haven't run into that many problems with that. It's one of the better tolerated. It's got a unique mechanism of action. Duloxetine, it's an SNRI, probably the best tolerated SNRI, so it does a little bit more than the SSRIs do. Has some pain indications. And then escitalopram being the cleanest SSRI. It doesn't mess with a lot of other receptors, doesn't have the interactions with other medications, things like that. Not overly sedating, not having any cholinergic effects, not overly stimulating, kind of your run of the mill. So those would be my A tier. Moving into the B tier, I've got kind of my next line would be like sertraline, fluoxetine. So those are the SSRIs that I would kind of think, next. They might be a little bit more effective, but they have a little bit more side effects. Sertraline's got a little bit of GI stuff. Fluoxetine's got the drug interactions. And then I've got mirtazapine in the B tier. I think mirtazapine's a great med. It does have the weight gain issue with it, but it doesn't have a lot of the other adverse effects that the antidepressants do. But because it does have that weight gain issue, I'm not putting it in my A tier, but I will put it in the B tier. And then I've actually decided to put dextromethorphan, bupropion, or Auvelity in the B tier. I don't like this med for the cost, but I do like it for its rapid onset and its effectiveness. Now, maybe that's just because it has bupropion in it, and maybe it's a little more likely to work. I'm probably not going to use it that much because of the availability and cost issue, but I do think it's, a tolerable, effective medication. And so that's why I put it in the B tier. If it didn't have the cost aspect, I'd probably put it in the A tier. All right. Next, C tier, I've put one of the MAOIs, tranylcypromine. I feel like that's the MAOI that's probably the best tolerated. The MAOIs in general have a lot of tolerability issues. However, they can be effective, especially if you've got a patient that's failed a lot of other stuff. They increase all the monoamines, and if you've got a patient who is not going to overdose, is going to follow the dietary restrictions, we're dealing with drug-drug interactions. There's a lot of stuff going on around the tolerability and just the complexity of prescribing the MAOIs. But as a medication, they're pretty effective. Okay, so that's why, and tranylcypromine probably being the most. I wouldn't not do the other ones, but I kind of rank that one a little bit better, and that's why I put it into the C tier. Um, and then I've got the tricyclics, right? These are also pretty good meds and maybe a little bit more effective than some of the newer meds, but they do have this significant tolerability issues. But in the C tier, I've decided to put desipramine and nortriptyline because they have the least anticholinergic effects, the least alpha blocking effects. They're the most well tolerated of the tricyclics. And so if I'm gonna choose a tricyclic and try and get like a different mechanism and maybe more efficacy, I would pick desipramine or nortriptyline. And so I put those into the C tier as well. I've also put trazodone in here. I would say if trazodone wasn't so bad in causing grogginess the following day, I might put it a little bit higher. I think it's a pretty effective med and it does help a lot with sleep. But because of some of the tolerability issues and maybe difficulty getting it to a therapeutic dose because of that, I put it in the C tier. But I do think that it is a promising medication and I mean, at least for insomnia, we do prescribe it quite a lot. So has a lot of utility. I put citalopram in the C tier. So out of all the SSRIs, I think citalopram is a perfectly good medication. I think it's pretty much as good as citalopram, but because of the QTc prolongation issues, and it's got a little bit of histamine blocking, a little bit tolerability issues with that the R enantiomer. And I think just because of its inferiority to S-citalopram, and we don't really need it, that's why I put it in the C tier because I think it's a fine antidepressant, but because of its inferiority to escitalopram, I didn't want to place it higher. So that's why I put it in the C tier. I decided to put desvenlafaxine in the C tier. So, I put duloxetine in the A, and I think desvenlafaxine is probably my next choice for an SNRI. It's got a little bit longer half-life than venlafaxine. It's got some advantages with not being affected by the CYP enzymes and not being metabolized by the liver, and then maybe someone has some liver issues. So there's some advantages to desvenlafaxine, and I believe it to be. It also, whereas venlafaxine is very heavily SSRI or SRI and not as much NRI, desvenlafaxine has like a better ratio, actually more similar to duloxetine as far as like helping with NRI as well. But it does still have some of the issues that venlafaxine does with its shorter half-life. So I do like this one next best. So I've put it in the C tier. And then I've also added ketamine to the C tier. Ketamine is the most effective as far as effect size. I actually made a mistake when I said it was around 2.0. It's ECT that's around 2.0 effect size. When I was talking about ketamine, I think I said it was around 2.0, but it's actually around 1.2. But that's substantially better than pretty much everything else. And so I think it's a great medication and a great option. I don't have it in a higher tier than C because of difficulty, kind of maybe availability issues. It's not FDA approved for depression. It's a newer treatment. Maybe we don't have as much data on it as we would like. There are some safety issues. It's cumbersome to give it. But I think from an effectiveness standpoint, um, that's why I did raise it up to C tier because of that. So I would say the S, A, B, and C tiers are the ones that I'm probably going to use the most often, and the ones that I think are the best options. Now, when we get into the D, E, and F tier, these are ones that I'm really have a lot of negative. These are ones where the negatives outweigh the positives. So, um, first in the D tier, we have the two remaining SSRIs, paroxetine and fluvoxamine. And that's, paroxetine's got the anticholinergic issues, short half life. Fluvoxamine, short half life. It lacks an indication for depression. So these are the least well tolerated, worst SSRIs. And, the other ones above it are superior. There's not a whole lot of reason to use these two, and that's why I put them to D tier. And then you've got the issues in pregnancy with paroxetine, so a lot of issues with those. That's why I put them in the D tier. I decided to put the other MAOIs and other TCAs that were not mentioned in the C tier into the D tier because if you're going to pick one, you should probably pick the ones that I put in the C tier. However, um, there may be reason they're a little bit more challenging. I would say some of the other MAOIs would be more. I almost could put them up a little bit higher, um, but I thought about putting maybe one other one in the C tier, but I think I'm just going to keep the rest of them in the D tier. If tranylcypromine, some of the MAOIs might be better for depression, some better for anxiety, some better in certain situations. You can go back and listen to the MAOI episode if you want to get more details, but they are a little bit more, have a little bit more adverse effects. So that's why I put the rest of them in the D tier. But I would say, maybe consider using them. Um, I mean, and the D tier I wouldn't say the D tier is a list that I never use. It's just one that I would very rarely. And so I put the rest of the TCAs in here as well, mainly because of the anticholinergic issues and sedation issues with those, whereas disipramine or nortriptyline tend to have less of that. And that's why I put them in the C tier. And then I've got levomilnacipran. When I talked about levomilnacipran, felt like there really wasn't much reason for it, and I didn't know why we'd want to use it. But I kind of theoretically thought of some things that it might be useful for, but it's not something that is advertised. But I think it's not a terrible med. It's not like it's not well tolerated or something. I just think that we don't have a lot of information on it. I think it's still, not generic. So it's a little more expensive and there's probably not much reason to think about it. So I put it in the D tier. And then S-ketamine, some people may, disagree with this one. They say, oh, S-ketamine, it's got like the 1.0 effect size and it's like this new great treatment that we have, go back and listen to the episode. I think ketamine's much better, despite the fact that this medication has FDA approval. That's more because just no one tried to get FDA approval for ketamine. Ketamine's better. It's got a better effect size. We don't have all the adverse effects. We don't have the REMS requirements. It's a superior product. And so, like, if you're going to pick one of these, I would pick ketamine. And still, I mean, these are cumbersome to deal with and the availability is an issue, and that's why they are lower on the list. And so, I put dextromethorphan bupropion in the B tier because I think it's a pill form. It's and not being a controlled substance, it's the easiest to get. Also, esketamine is very expensive, and ketamine isn't. So ketamine has a lot of advantages over esketamine, and so I would say if in my personal opinion, if you're able to get ketamine or esketamine, I would pick ketamine, and that's why I put esketamine in the D tier. Perhaps if they get the oral version of esketamine, which I've heard is coming out, perhaps I might move it up to the C tier because that would mitigate a lot of the difficulties that we're having with it now. That might be a reason to move it up to the C tier. But I'm not sure. It's still costly, etc. and doesn't work as well as ketamine. But I think I feel comfortable having it in the D tier. As you know, if you're going to pick a NMDA antagonist, that would be my last choice. And then I put vortioxetine in the D tier. Vortioxetine, I don't really think it has much to offer that the SSRIs don't, but I think it could have some utility. And so, whereas vilazodone I put in the E tier, I think vortioxetine's a little bit better. I put it in the D. So in the E tier, I put, as I mentioned, vilazodone. I don't think there's much reason for vilazodone. I think that you could just create it by mixing buspirone with an SSRI. Um, Vilazodone's got issues with having to eat on it. It's got the 3A4 substrate that other drugs will interact with it a lot. Buspirone also is a 3A4 substrate, so you would have that same issue. But buspirone also has the 1PP metabolite that has some benefit that vilazodone doesn't have that. And so I think just because it's just, I don't think it really adds anything. I don't think it's a terrible med, and it's not that expensive now. But I don't really think that it has much to offer when we compare it to all the other medications. Um, and that's why I decided to put it so low. And then also in the E tier, I put venlafaxine. As you know, I don't like venlafaxine. This is probably another one that other people would not agree with. They'd probably put venlafaxine in the B tier or something like that. I'd say if you're going to pick an SNRI, why not go with duloxetine? It's better. Even levomilnazepram, I feel like is better. Venlafaxine's got this short half life. People have such problems coming off of it. Um, I just, there's so many other options, and that's just such a terrible adverse effect that you get. Now, not everyone gets it, right? Not everyone does get that. I mean, I've had patients on it, and they haven't had these issues, and they've done fine with it, and they could get off of it. I've had some really bad experiences with a handful of patients, and I would say out of all the medications listed on this list that I've prescribed, I've had the most problems with venlafaxine. That's the one I've had the worst reactions to, the worst adverse effects, the worst withdrawal. Just personally, I have seen the worst outcomes as far as like just tolerability issues with venlafaxine of any of these medications, and that's why I put it in the E tier. Um, I think it's a lot more popular medication, but like I said, desvenlafaxine I put in the C tier. I think desvenlafaxine is much better. I think duloxetine is much better. I think levomirazepam is much better. I think milnacipran is probably even better. If you're going to pick an SNRI, venlafaxine should really be your last choice. And just to emphasize that, I put it in the E tier. Maybe it doesn't deserve to go that low, but I think it does. And then I've also put nifazodone in the E tier. I think nifazodone is something that you could consider. It's not something that people are using, but I think with the black box warning on hepatic failure, that just makes it, are you really going to take your risk with nifazodone? Is it really offering you something that you can't get from, say, trazodone or some other things? It does work a little bit differently. It's something that you might consider, but like pretty much nobody's using nifazodone, and that black box warning is a big reason why. But also, it has a lot of the same issues with sedation and so forth that trazodone does, but a lot more risk. And then it's also a 3A4 inhibitor, right? Like fluvoxamine. Or one I don't think I mentioned another reason why I put fluvoxamine so low in the D tier is that that um, it's got that issue with being a strong 3A4 inhibitor. And not just that, fluvoxamine, remember, inhibits most of the CYP enzymes. And nifazodone is also a strong 3A4 inhibitor. So not only does it have the black box warning, but it also interacts with a lot of medications. And so for that reason, I feel like the E tier is where it belongs. And then, last but not least, Gepirone ER. We talked about that was our last medication. I hate Gepirone ER. I've never used it, never seen it. Hope I never do. The ECT, sorry, not ECT, EKG monitoring, and just a host of issues eating with food. It's a 3A4 substrate as well. but mainly the warnings for EKGs and having to get electrolytes and correct electrolytes and monitor the EKGs so much because of QTC prolongation. And just the fact that it took so long to get approved because like they just could not prove that it worked. And so you've got a medication that really we have no evidence works better than anything else, but has this massive warning on it. And then we have this sister compound, buspirone, which basically works exactly the same, but doesn't have the same risks and is much cheaper as well. That if we wanted to use, we could just use that one. Gepirone, I think it's just, it never should have happened. Uh, I don't know why anyone would prescribe it. I'm not going to say that, someone might not have improved after they took it, but honestly, I think anyone that got better on Gepirone probably got better just because they were told this is a new drug, this is the newest drug out there, and it's more expensive, and it's not a generic, it's the branded product, and I think it would just be a lot of hyped placebo. I don't think that it actually does anything more. Maybe because that's the thing, you take generic buspirone and branded product gepirone, and just the placebo is going to be higher because, oh, I'm taking a branded product, oh, I'm taking a newer product, oh, I'm taking the newest product. And so I think most of the benefit that someone might experience with gepirone would all be kind of like hyped placebo effect and not actually what the drug is doing. And just the risk and just having to monitor so much, like who even has the ability to check as many EKGs as you'd have to for this? And who would want to mess with that? Not me. So I'm very comfortable putting Gepirone ER in the F tier. So I hope you found that tier list to be useful. I had a lot of fun making it and deciding why and which tier I would put everything in. And hopefully that helps you kind of think about how you maybe make your own tier list. It doesn't have to be mine, but maybe that helps you kind of formulate which ones that you might want to use. And I think a lot of people, what they do is they find one they really like and they just go to it over and over and over again. When I was working in the military, I would get patients handed down to me from other people, or I'd be filling in, and I would find that every single patient that this person saw was on the exact same medication. Very often that was sertraline. And I would just be like, they've obviously put no thought into this. All right. And that's why we're having this episode today, how to pick the med. I may like bupropion, duloxetine, and escitalopram the most and put them in my A tier, but one, that's not just one medication. I've got three that I go to on a readily on a regular basis. But yeah, do I reach for mirtazapine? Sure. Do I reach for fluoxetine, sertraline? Sure. Do I, occasionally do some of these other things? Yeah, I do mix it up. I do take all these factors into consideration when I'm picking what med I'm going to give to somebody. All right. I don't just pick the same med for everyone. I think if you're giving a placebo response and you're doing mostly kind of therapeutic type of stuff, maybe that's all you need. But I think if you put a little bit more thought into it and you understand things a little bit more, you might get a little bit better results. Okay. Going with the safe option like that, you know, maybe you'll do okay. But like, I mean, come on, you're a psychiatrist. Like, do you want to just do what's boring and monotonous? Is that is that what you think they're coming to you for? They could go to their primary care doctor and get that, right? They could go to anyone and get that. They could get that from their OB-GYN. They could, they're coming to you because the issue that they're having is more severe than giving the most monotonous, boring, run-of-the-mill, same treatment over and over again. They're coming to you for something a little bit different, to think about half-life, to think about how their age might be impacting it, to think about how other medical conditions and other side effects and family members and genetics and all this stuff, all these factors we're talking about, that's where they're coming to you. And so you need to take that into consideration. All right. So I've got one last slide in this episode, and it's kind of repeating what I've said before. So it's the American Psychiatric Association practice guidelines from 2010. I couldn't find any newer ones. Maybe new ones have come out, but this just kind of reiterates what I've kind of come up with on my own. They have level 1 recommendations, and they say that SSRIs, SNRIs, bupropion, TCAs, and MAOIs are comparable in effectiveness. SSRIs, SNRIs, mirtazapine, and bupropion are optimal for most patients, and MAOIs are reserved for treatment resistance and atypical depression. Now, I think that's pretty much the message that I've been giving you I think that kind of fits the tier list and our discussion on, effectiveness and side effects pretty well, where I put, I pick an SSRI, I pick an SNRI that I like most, I pick mirtazapine, bupropion, and I would say those are optimal for most patients. That's my experience. And here we have, not just, Dr. Armstrong's opinion. We have the American Psychiatric Association's practice guidelines, which are very much in line with what I'm already saying. And just one word, since I mentioned how they said that MAOIs are reserved for atypical depression, just to remind you all what atypical depression is. Now, this is a subtype. I could add this to the subtypes, but we're just going to mention it here because it's real quick and easy. Atypical depression, if you'll remember, hypersomnia, so sleeping too much rather than not enough, hyperphagia, overeating instead of loss of appetite, leaden paralysis, so, just stiff and can't move and just doesn't get out of bed, doesn't do anything, and interpersonal rejection sensitivity. So any kind of perceived negative feedback from a social environment, they take it very, very much to heart and very much affected by it. Those four symptoms are kind of clustered together to describe what atypical depression is. And there's been research to show that MAOIs might be a little bit better at treating that than some of the other treatments. I've also heard that maybe that's not true, but it's something you could consider if you've got a patient like that. I'm certainly not going to pick MAOI first anyway. I've got it, fourth on the list. Maybe you could move it up to third on the list if you've got a patient like this, or if you are fourth on the list. I had several options for what to pick fourth, and maybe you pick MAOI as your choice for that option if you're seeing these symptoms. So that's the APA's practice guidelines. I think pretty much in line with what I have to say. So hopefully, you've kind of gotten an idea of the different factors you should be thinking about when you're going to pick a medication, and some details on how you might go through that. I went through a lot of that in detail. There's a few things as far as subtypes and age and so forth, and reproductive status that we're going to discuss in later episodes, but I brought them up now just to mention them as factors. And then I gave you my algorithm, I gave you the APA's guidelines, and I went over my fantastic tier list where I explained to you why I think some of these medications are better and kind of rank ordered them for you. So I hope you enjoyed this episode. Next time, I'm really excited about this next one. I think I might break it up into 2 episodes, and I'm going to basically talk about the effectiveness. Now, I know I've mentioned this a lot in the episodes, but we're going to go over what the exact effect sizes are for the meds, how to make them more effective. I'm going to talk more about placebo. I'm going to talk about how to become one of those psychiatrists or practitioners who can harness the power of the relationship with the patient to get more effect as you're prescribing. I've taken a lot of this from someone who's done a lot of research in this. So I'll give them credit when I talk about it, but I've kind of tried to put it together in my own way. But this next couple episodes are going to be great because they're going to be how to take everything you've learned about the meds, everything you've learned about how to pick the meds, and now we're going to be talking about how to utilize them, how to actually give them and make it to where we get the best bang for our buck. And I think that's going to be really, really informative, and I look forward to it. I want to thank you so much for tuning in. Please rate, subscribe, follow, tell whoever you want to let them know how great this podcast is, and I will see you next time.
It's my decision, can't take it away. I'll have it my way, I'll make my own mistakes. Why don't you listen? Your mind is your voice, your heart is your choice. It's